Good afternoon to everyone, and welcome to the meeting this afternoon. Hope that you're all well and warm on this cold winter's evening. The G-ECHO is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. And these sessions are held weekly on a Wednesday at 4:30 usually. We're just about to begin, and the chat is open for questions, so please feel free to include questions there. They're very welcome, and we'll canvass them at the end of the discussions. In discussion this afternoon, I'd just like to give a word of thanks to Dr. Lala and Professor Thompson for the opportunity to present one of our cases here. And then it's in order for me to welcome Dr. Jack Turyahikayo. He's our GI fellow at the University of the Free State, and our trusted pathologist from AMPAT Laboratories, Dr. Edward Miles. We'd like to welcome the two of you, and we look forward to your contributions to one of our challenging cases. So with that, the order for the afternoon, then I'll just give a short introduction to the case. Will be followed by a session, a discussion on the case by the fellow, Dr. Jack. And then we'll conclude with Dr. Edward Miles, who will then round things up with the histology as we often manage these cases. And then we'll take it from there and hopefully get some help into the case as well. So I'm going to share my slides. Let's start. Fine. So to kick off, I think it's going to good. The case we're going to discuss this afternoon is that of a 40-year-old male who came to see me or us at our gastro clinic in the beginning of 2021. He was at that stage and still is an insurance broker. He had a medical history of hypertension and class 2 obesity, and he was seen primarily for the further care of his dysmetabolism, incidentally newly diagnosed with non-insulin dependent diabetes. And he complained there of an altered bowel habit and was duly referred for lower endoscopy. So he had this endoscopy scheduled, and I performed this endoscopy, and there were in the rectum multiple diminutive-looking polyps, of which, to me, many of them, as the pictures here, appeared like adenomatous polyps, and I removed, those that I could see. I classed them as polypoid and sessile, Paris type 1S. And I removed what I could see with cold biopsy and snare polypectomy. And I retrieved them, as many as I could, and I sent them for histology. So the histology back then said 6 samples identified. And as I was reading the report, the word tumor sort of jumped out at me, and it said identified in 4 with microscopic features of neuroendocrine neoplasm. And with the immunohistochemistry in keeping, with strongly positive synaptophysin and chromogranin, and then nuclear positive signals in the Ki61 of less than 3% of the tumor cells. And scarily for the patient, his report said neuroendocrine neoplasm grade 1 and malignant neoplasm of the rectum. So this put him on quite a spin and a spiral, and being an insurance salesman, he walked the road of dreaded disease and all these forms that we had to fill in. We did blood work on him, and it was largely normal, apart from his new diabetic conformation. His chromogranin A was normal. His 5-hydroxyindolacetic acid levels were normal. At the beginning, we did do an MRI. We didn't have endoscopic ultrasound or anal ultrasound at that stage. And the MRI showed multiple focal areas of restricted diffusion in the mucosa, suggestive of sinister cause, but there was no extension beyond the wall to the mesorectal fat. I did a scintigraphy at that stage, and there were no metastatic features. So no systemic symptoms. He came in for elective screening, basically an altered bowel habit for a screening colonoscopy for cause, and no systemic features, and now this on his endoscopy. We then discussed him with the colorectal surgeon that was with us at that stage, and we had a discussion amongst ourselves, colleagues here, and the thinking was with the patient that this was really a indolent grade 1 scenario. The colorectal surgeon with us at that stage felt that we should just leave him alone and not bother about this, and we shouldn't have removed the diminutive polyps from the rectum anyway. And yeah, so I went on this road to try and follow him up with watchful waiting. And this histology report is the thing that sat with him throughout the time. So we followed him up in 2022. The lesions looked exactly the same. I removed, I think there were two. I didn't send those for histology. Then 2023 he did not come back. 2024, same story. We saw him and there were biopsies again done. They were done at a different laboratory and that showed the same picture. And then in 2025, he returned, and at the end of that year, last year, on rectal retroflexion, this was what we saw. So I measured this at about 1.5 millimeters in its longest axis, and it was really close to the anal verge on retroflexion. That's the narrowband imaging. And I elected primarily to not do any biopsies here, anticipating some form of a endoscopic procedure to remove, and opted for the MRI again to compare with what we had in the earlier MRI. His blood work was again normal. His systemic features of neuroendocrine excess were normal, chromogranin A normal, 5-hydroxyindolacetic acid normal. We had an abdominal pelvic ultrasound, which was also unremarkable, a bar for hepatic steatosis, and then the repeat MRI. So this is the MRI, which we could only get a date in February this year, which shows just on the T2 weighted image, a break or a disruption in the mucosal line in the rectum. And I just want to see for a pointer. Okay, but just on the right-hand side of your image, you can see, there's the pointers. So just there, a disruption in the mucosal line, and then a creeping into the mesorectal, past the or into the muscularis there, rectally. And then that was very concerning for me, with thickening, in the lumen as well, which was expected then. And then on a T1 weighted image here, we see that there is a lymph node which is there. So that was a bit concerning or scarily concerning. So this lesion was measured on MRI to be 13 millimeters, not the 1.5 centimeters I'd guessed. And it was 3.7 centimeters from the anorectal junction. They reported this disruption of the muscularis mucosa extending into the fat, but of 1 millimeter less extension. They said 1 to 3 suspicious small lymph nodes on the report. I only seen one. I think the others are very much smaller. There was no fascia or extramural vascular invasion. And then the conclusion on that was patient known with rectal cancer with radiological features in keeping with the TNM stage of CT3A, N1, and then we didn't have the metastatic features or classification at that stage. Imaging further showed that there were no metastatic involvement of this patient. So what happened was I had the discussion with him that he had to be seen, by a colorectal surgeon for opinion, and his wife is one of the senior nurses in our center, and she said that this is a big thing that I'm discussing, and the prospect of surgery for this was a lot for them to bear, and they actually opted for another opinion. They saw somebody else, and they elected to repeat the endoscopy. and then biopsied a number of these diminutive lesions again. I have it on understanding that the actual lesion was not biopsied again. But yeah, and that histology comes back with the same neuroendocrine strongly positive synaptophysin and chromogranin A, chromogranin strongly positive with a Ki67 index much lower than it was in 2021. So on that report, it says neuroendocrine cell micronests, and there's no mention of rectal cancer or malignancy on this report. So they come back to me to say, but the doctor says that there's no cancer here, and we sit with this dilemma. So the thoughts on the case are, a low-grade rectal neuroendocrine tumor versus this entity of neuroendocrine rest, micronest. The distal rectal lesion that we see now of concern, it's more than 1 centimeter now, close to the anal verge. The current MRI, which is showing a disruption there and its creep into the mesorectal fat, the lymph node, and obviously we are uncomfortable with watchful waiting here. Endoscopic resection sounds like it's not an option anymore. And then there's this prospect of major surgery with an extremely anxious patient. So before we make comments on these, I'd like to then stop sharing and hand over to Dr. Jack, who will take us through this entity of neuroendocrine cell micronests, which was it was a new thing to us. Let me say that. I'll hand over to you, Dr. Jack. Thank you.
Thank you, Dr. Simmons, for the kind introduction. Okay, so I will this afternoon take us through this very interesting subject, rectal neuroendocrine cell micronests, which are rather incidental, more often than not indolent. But of what importance do they have in terms of progression of disease? I think we'll have good discussions at the end. So to start off with definitions, neuroendocrine tumors are well differentiated neuroendocrine tumors, usually more than 0.5 centimeters with invasion, and usually staged as WHO grade 1 to 3. In contrast, neuroendocrine cell micronests are really clusters of neuroendocrine cells in the lamina propria, which are quite much smaller, less than 0.5 centimeters. And it's important to note that they are without invasion beyond the lamina propria. The older term for these lesions is the macrocarcinoids. That has been phased out, and now the entire group, is called micronests to sort of signify the lesions without invasion. It's important to remember that size, invasion, and grade are all important to decide on management, and not just the presence of neuroendocrine cells. As regards the epidemiology and clinical setting, in terms of the data, the incidence of these lesions is highest in the Asian, Hispanic, and Black populations. And, by and large, rectal neuroendocrine tumors account for more than a third of all gastrointestinal nets. Fortunately, over 80% are quite small lesions, less than 10 millimeters, and 90% of these lesions are confined to the submucosa and are considered or graded as low grade. that is helpful because there's only a 2.5% metastatic risk of these lesions. The incidence of these lesions seems to be growing, based on the fact that there's a lot more screening for colorectal cancer, and most of these patients are asymptomatic. So these lesions are usually incidentally found on a screening colonoscopy. There are associations in the literature that have been, uncovered with the micronests, especially adenomas, patients who have inflammatory bowel disease, alveolar colitis, and dysplasia. In regards to the endoscopic appearance, this is just an image showing what they look like, similar to the patient that we have. These are usually small, less than 5 millimeter lesions in the yellow-white submucosal nodular appearance. The mucosa is usually intact. They are often in the mid-rectum, about 8 centimeters from the anal and they tend to look somewhat like hyperplastic polyps or lipomas or even lymphoid aggregates. So more often than not, endoscopists will biopsy them, for histology, and usually it is the histology that alerts the treating doctor about the net diagnosis. It's important to remember that there is a poor diagnostic yield on forceps biopsy because these lesions tend to grow into the submucosal. And fibrosis can eventually make endoscopic resection difficult. So at the outset, if the endoscopist is somewhat sure about the lesion, then it is preferred to have a discussion with the MD team for endoscopic resection to achieve complete resection margins. As regards the histology, so these appear as nests of monotonous cells in a trabecular pattern. They do have a coarse nuclear chromatin with a salt and pepper appearance, as highlighted in the diagram, and they have a highly granular cytoplasm. They do stain positive for cyanophycin and chromogranin, and also do express the CD56 receptors. The mitotic activity is usually based on the Ki-67 index, which tends to be low, less than 2%. Is usually no mitosis and no lymphovascular invasion. And as I said, these lesions are confined to the mucosal submucosa with no vascularis propria invasion. So in terms of the grading for the mitotic activity, the grading has mainly two entities that are used, the mitosis grading and the Ki-67. And grade 1, which is usually 80% of the micronests, that's less than 2 mitosis per 10 high power field, and a less than 2% Ki-67. Grade 2 is considered intermediate and is up to 20 mitoses with up to 20% Ki-67. Grade 3 is considered high grade, and that's is scored as more than 20 mitoses per 10 high power field and a 20% Ki-67. And large, in terms of cutoffs, grade 1 is low grade, and largely G2 and G3 tumors are considered fairly high-grade tumors. So in terms of risk stratification, there are mainly 3 questions to consider. And one is size, you know, how big the lesion is, and anything less than 10 millimeters is considered very low risk. 10 to 20 intermediate risk, and more than 20 is high risk, and that should be considered as the typical neuroendocrine tumor. And as regards invasion, what is key to remember that invasion into the muscularis propria portends a high chance of metastatic risk to regional lymph nodes. So that should be really regarded as a net, irrespective of size. And then grade is to do with the behavior of the tumor. So as I earlier said, lesions that have a Ki-67 index of more than 3% and mitosis more than 2 per 10 high power field, those behave as G2, G3 tumors. So just a note that the European Neuroendocrine Tumor Society quite highlights that tumors without invasion that are less than 10 millimeters and as staged as G1 tend to have a benign behavior. So in terms of workup, you know, the approach, you know, in terms of the guidelines, 2023 INETS guidelines, do recommend that patients who have the typical neuroendocrine cell micronests less than 10 millimeters and are completely resected do not need, you know, further tests. So they don't need further endoscopic ultrasound to check for invasion. They do not need MRI of the pelvis, and neither do they need a gallium-68 PET scan. They only need, you know, routine colonoscopy screening for colorectal cancer. Patients with lesions between 10 and 20 millimeters or who have incomplete margins on resection do need EUS, you know, to look at the depth and invasion of the tumor, and you have to consider MRI of the pelvis, and they also need PET scanning, you know, to look at the tumor spread in the regional lymph nodes or even distant nets. And they need to have a 1-year follow-up for colonoscopy. Patients who have more than 20 millimeters or muscularis invasion, they do need all these tests and should be staged as NET. So in regards to management, endoscopic resection is the key to management of these lesions, and the technique recommended is modified EMR or endoscopic submucosal dissection for complete histologic assessment. The goal is to achieve R0 resection and confirm no invasion or G2 features. So if there is complete excision for lesions less than 10 millimeters, which are G1, which have a very low mitotic index, and there is no lymphovascular invasion demonstrated on immunohistochemistry, then these patients don't need further treatment, and there is no surveillance beyond routine screening. However, if you know, there is incomplete resection or if the lesions are more than 10 millimeters, then the recommendation is to repeat colonoscopy and EUS at 3 to 6 months, and to consider the more precise excision techniques. So that's transano endoscopic microsurgery or transano excision. So these are the variable methods of endoscopic resection that are recommended. I think it's important to remember that conventional smear polypectomy has a complete resection rate which is very low, up to 30%, and is therefore not recommended because it does not achieve R0 resection. also, just to remember that conventional EMR, the complete resection rate is up to 80%, and therefore all these other techniques of modified EMR are quite recommended because they do give better completion, better complete dissection rates. So EMR with transparent cap, with band ligation, pre-cutting, and anchored snare tip are all recommended. It's important to remember that there are adverse events with each of these modalities, and notably hemorrhage and perforation. And I think EMR with band ligation has the lowest adverse events with very good complete resection rates. This is the management algorithm, and not only looking at the micronests, but looking at the rectal nets in totality, because these lesions do advance, and I think it's important to, at whatever stage that the patient is diagnosed, to know what the approach is. So, therefore, for biopsy confirmed nets, ideally it's to have a staging workup for these patients, as earlier stated, EUS, MRI, CT, PET scan, and lesions less than 1 centimeter. The recommendation endoscopic is endoscopic resection or endoscopic full thickness resection. If complete resection is achieved and there is no lymphovascular invasion, no follow-up needed. If it's a G2, G3 lesion with lymphovascular invasion demonstrated, then these patients do need follow-up. And if there is a regional lymph node mets, then they either qualify for oncologic surgical resection or even a endoscopic resection. Just that applies for the same as patients who've got incomplete initial resection, do qualify for a endoscopic resection or oncologic surgical resection. Oncologic surgical resection is more radical, but it's intended to curb disease spread. I think the modalities there is lower anterior resection or abdominal perineal resection with total mesorectal excision. Patients who've got lesions between 1 to 2 centimeters, there is usually a discussion whether they qualify for endoscopic resection versus oncologic surgical resection based on the lymph node metastasis. So by and large, patients who've got lymph node mets should have surgical resection. And then lastly, patients who have lesions more than 2 centimeters, and those either qualify for chemotherapy or surgical resection based on whether they've got metastatic disease. So if they've got metastatic unresectable disease, they do qualify for chemotherapy. And if they are resectable, then they do qualify for oncologic surgical resection. So that's sort of the approach to RNETs in totality. But I guess for the context of our patients, we probably have to discuss, endoscopic resection and surgical versus surgical resection. This is a slide to show when to resect the rectum. These are the indications for total mesorectal excisions. Is lesions more than 20 millimeters, invasion into the muscularis propria demonstrated in EUS or MRI, lymphovascular invasion demonstrated on immunohistochemistry staining, grade 2 or grade 3 lesions, which are quite highly active and mitotic, and then lymph node spread, which is demonstrated on imaging. Fortunately enough, less than 5% of micronests do need surgery, and the majority are managed endoscopically. So in conclusion, there is a size and depth rule, when looking at approach to, NCMs, and that patients who've got complete resection, less than 10 millimeters, no invasion, those should be discharged, no need follow-up. The grade matters in this case. The Ki-67 is always helpful. More than 3% should always be regarded as a neuroendocrine tumor. Complete excision is curative for these true, NCMs. And there is a role for multidisciplinary discussion for lesions between 10 to 20 millimeters, or any adverse histology thereof. And it's important to remember not to label these patients as having cancer, because then it spirals into a whole discussion of more aggressive treatments, and yet they could benefit from good endoscopic resections. And lastly, we need to remember to avoid patient anxiety, especially if we are confident that the histology confirms NCMs, which we know are quite benign and indolent lesions. Those are my references, and thank you very much.
Thank you very much for a thorough overview there, Dr. Jack. That was well appreciated. So I think from what you're saying, our patient fits into that less than 5% then, unfortunately. So I subsequently then called our trusted histopathologist to just get clarity on these conflicting results, and then I'll hand over to Dr. Edward Miles, who will conclude, and then we'll have discussion afterwards. Thank you, Dr. Miles.
Yeah, thank you very much. Can you all hear me?
Loud and clear, thank you.
Excellent, thank you. So I'll present the case in the order how I approached it with the first biopsy that I received now in 2026. So we received a series of endoscopic biopsies in March of this year, and a total of 8 specimen containers were received from the rectum, as well as from the sigmoid colon and rectosigmoid junction. Just get my laser pointer. So this is just a overview of the slides. These are not all the slides, but these are just the 8 specimens that were received. So overall, there's representation of mucosa with muscularis mucosa and some representation of submucosa. Notably, throughout these specimens, the colorectal crypt architecture is mostly maintained.
Dr. Miles, sorry, we're not seeing the slides.
You're not?
Not. Sorry about that.
I'm sorry, let me try again.
We see your full screen.
You see it now?
Perfect. Perfect. Thank you.
Sorry about that. Okay, so there's the sum of the sections of the 8 specimens, and as I said, the colorectal mucosa with, in some of the specimens, representation of muscularis mucosa, and you can see this is somewhat fragmented, so there's some submucosa in between. This is basically biopsy artifact, and throughout the colorectal crypt architecture appears undisturbed and relatively uniform. Notably, one can see is that the lamina propria in areas are bluer than expected. So that's an increase in cellularity of the lamina propria, indicating inflammatory infiltrate. And this inflammation is most notable in specimen 6, where the lamina propria is expanded by dominantly chronic infiltrate. And I'll later show some neutrophilic activity. There's also evidence of injury to the surface epithelium. However, importantly, the crypt, although the lamina propria is widened, the crypt distribution is still uniform across the mucosa. The crypts show uniform rounded profiles. There's no branching, no significant dilation. So there's no evidence of chronicity. This is specimen 7 and 8. Again, uniform architecture and variable representation of submucosa. Due to the fact that we were provided the history of a previous neuroendocrine neoplasm, I was on the lookout, and in areas, neuroendocrine nests could be identified in the basal lamina propria. There's some muscularis mucosa represented, so this is the basal portion, luminal portion there, and only focally larger nests were identified. This is one of the larger ones, which measured 200 micrometers in diameter, 0.2 millimeters. And this is the largest one, 275 micrometers, which is just under 0.3 mm in size. So they're less than a half a millimeter in size. Cytologically, there's a uniform cellular proliferation of epithelioid cells showing amphiphilic cytoplasm, so a combination of blue and pink staining with a granular character, and rounded nuclei with evenly dispersed chromatin, absent nucleoli, no cytological atypia, and no mitotic activity. This is hallmark features of neuroendocrine cells. And this is a higher magnification of the area of inflammation, so highlighting the hypercellularity of the lamina propria. Now, at this time, noting the neuroendocrine proliferation, immunohistochemistry was performed across the specimens. And in this biopsy, for instance, where initially on H&E assessment, I only saw a mild active colitis, a neuroendocrine cell proliferation was highlighted. Small discrete neuroendocrine nests among the crypts in the lamina propria that do not disturb the local architecture. And to highlight the subtlety of the proliferation, it's very small nests. And in this field, there are many, and I can't even pinpoint all of them. Very, very subtle. There's the neutrophilic activity. One can see more regenerative appearance of the mucosa with loss of the goblet cell features. And this neuroendocrine proliferation was highlighted on all my immunostains that I did through these specimens. So these two larger nests are highlighted here. However, the background, small nested proliferation is noted. Interestingly, on this slide is that there are also neuroendocrine cells in the crypts of between the epithelial cells highlighted. Now, gastric neuroendocrine cellular hyperplasia is a well-defined entity, but this is not at all explained in colorectal. And however, morphologically, this very much mimic what I would expect to see in a neuroendocrine cell hyperplasia. Again, under biopsy showing this nested neuroendocrine proliferation in areas a bit more scattered. And these nests were completely unidentifiable on H&E examination without very close scrutiny. At the time when I saw this, I was perplexed because the features I'm seeing is not classic of what we expect in the neuroendocrine cell neoplasm. And upon literature search, I came across this entity of neuroendocrine cell micronests. And these are images from reported literature where there is an even more pronounced nested proliferation of neuroendocrine nests in the colorectum. In this instance, extending into the muscularis mucosa. This is a low quality image, however, showing a very similar immunohistochemical profile as that what we saw in the current 2026 biopsies. So at the time, with caution, I diagnosed neuroendocrine cell micronests and confirmed that I'm not seeing diagnostic features to confirm a neuroendocrine neoplasm. Notably, background active colitis was appreciated. And to highlight the rationale behind this diagnosis. Although the provided clinical features and the imaging suspected a neuroendocrine tumor, and we have a previous biopsy diagnosis, my cytoarchitectural features completely fit with the prescribed features in the histopathology literature. I didn't have a discrete mass lesion. There was no notable architectural distortion. The proliferation was microscopic and diffuse, so it was not truly measurable. And in that sense, it was scattered and non-confluent. There was no associated desmoplastic stromal response. And the epicenter of the lesion was in the basal lamina propria, with only minimal involvement of the muscularis mucosa, which is allowed. Notably, although I didn't see lymphovascular invasion, that's not a common feature in low-grade neuroendocrine neoplasms. And the immunohistochemical profile is completely identical compared to a low-grade neoplasm. So in that case, it's not contributory. As is routine with difficult cases, if previous biopsies were received, we will review those specimens. So we retrieved the 2021 biopsy from filing, and at the time 6 endoscopic biopsies were received. Again, with representation of architecturally sound colorectal type mucosa with focal representation of muscularis mucosa and submucosa. And in this specimen, a well-defined neuroendocrine lesion is present. Microscopically, this one measured 1.5 mm in diameter, so much larger than what we experienced in the 2026 specimen. Notably, there's an associated stromal reaction with splaying of the smooth muscle and some fibrous or fibroplasia. Cytologically, though, it is diagnostic of a low-grade neuroendocrine neoplasm, and this was mirrored on the immunohistochemical stains, showing diffuse strong neuroendocrine marker positivity. So synaptophysin and chromogranin showed this identical profile, and a very low Ki-67 proliferation index compared to the basal portions of the crypts, which is the proliferative compartment. Very interestingly, reviewing this case now in hindsight, in one of the biopsy fragments, I noted on the immunohistochemical stain this very subtle neuroendocrine proliferation in the background. Now, the reality is, in a neuroendocrine neoplasm such as this, it is a straightforward diagnosis. We will make sure not to miss anything, but the report is very self-evident. There's hardly any difficulty with this. So at the time, and especially since neuroendocrine cell micronests were not described in 2021 yet, my colleague merely ignored this as just a background alteration. And interestingly, on H&E, the proliferation is so subtle, it comprises these very small isolated nests between the crypts. At this time, my concern was the fact that we have a confirmed neuroendocrine neoplasm with similar alterations in an adjacent biopsy to what we're seeing in 2026, is that are we seeing a not well defined secondary reaction to a deeper neoplasm? The fact that in the fact that we do not have a defined identifiable endocrine neoplasm in our current 2026 biopsy series, the concern is this reacting to deeper pathology? However, on search of the literature, no such reaction has ever been described. And very importantly, this growth pattern is not at all described in neuroendocrine neoplasms. So this is not a feature of disease progression or an infiltrative form of growth. Basically, and I showed this case to my colleagues as well, this is not a pattern of growth that we see in neuroendocrine neoplasms. So on review of the histopathology literature, I'm going to briefly touch on this. I'm going to try not to repeat too much that has already been said, but this is a rare microscopic non-mass forming neuroendocrine proliferation. And we've noted that there were previous terms, including microcarcinoids and neuroendocrine cell dysplasia. We have noted that there's associated with inflammation. And importantly, in our 2026 biopsy series, there is a definitive active colitis. Though these are usually incidental and not associated with a previous mass lesion, so the connection here is uncertain. There's no clear size criteria reported, and as has been mentioned, they typically measure less than 0.5 mm in size. And the available evidence currently suggests an indolent clinical cause, and that's why in my report, I couldn't justify recommending more aggressive therapy based on what I am seeing. And just to mention, if I receive biopsies for a neuroendocrine neoplasm, and the question is there the disease progression? Generally, I'm expecting an increase in tumor burden with a larger tumor represented as well as more extensive tumor. However, it must still be a defining tumor mass, a discrete measurable mass. So generally, progression in these tumors are characterized by an increase and progression of the anatomic extent of the disease with local and regional spread. So there's an enlargement of the primary lesion with the formation of a defined space occupying mass. There's progressive mural invasion from the submucosa to the muscularis propria and serosa. There may be lymphovascular invasion and also metastases. Rarely, low-grade neuroendocrine neoplasms may progress in the sense that they change grade to a higher grade lesion due to acquiring new genetic alterations. However, in the context of our current discussion, this will be histologically easily evident, where you have a notable cytological atypia and an increase in mitotic activity, as well as Ki-67 proliferation index. So to finalize, at the time represented in my biopsy, there's a microscopic basal lamina dominant, non-confluent, non-mass forming neuroendocrine proliferation, and the findings supported the diagnosis of neuroendocrine cell micronests. However, in view of the imaging findings, I am still concerned of possible deeper pathology. Thank you very much.
An immense thank you, Dr. Miles. I think it's always amazing to us how histopathology brings such relevance to difficult clinical scenarios and sort of clears out many times. So I think in this instance, it's evident, and the theme that's coming out is that these neuroendocrine cell micronests are often in response to something. And they may be something benign like a colitis, focal active colitis as well. Obviously, this patient, you have raised the issue as to whether the net is causing the secondary micronests. And that one, is there any way to differentiate the two between the nests being caused by the tumor or the nests being caused by some benign process like colitis? Are there any fine differences there, perhaps?
So in the literature available and in what I'm seeing, there's basically histomorphologically, what you are seeing will be the same. You'll see a small nested proliferation of neuroendocrine cells in whichever context, be it a context of a colitis or an adjacent mass. The question I would have for my own colleagues is, has anyone gone back to diagnosed confirmed neuroendocrine neoplasms and seen if there is an associated neuroendocrine proliferation in adjacent mucosa, as I've seen in this one case? I just think maybe because the diagnosis of neuroendocrine neoplasm is relatively straightforward, mostly, especially in a well-representative sample, that one would not interrogate isolated small nests in the vicinity. So maybe, no one has thought to have a look at a series of these cases.
Certainly, that sounds like work that needs to be done.
Yeah.
So thank you very much once again. I'm going to just put up that slide of mine of the questions that we had, and then I'm going to open the floor for questions and queries from anyone. So I think the way forward, or how I understand it, is that what we will be doing is for now the watchful waiting, and we've elected with this disclarity to watch the patient and then rebiopsy him in 3 months' time. Endoscopy and rebiopsy. And just see. I think the idea would be to try and see if we can get any clarity there, but to repeat that MRI as well, and then from there to make a decision. We've canvassed this with the colorectal surgeon locally, and they agree with the waiting for now. The support of waiting was the thinking that that little node may be something that is responsive to whatever else is going on in the colon, and that we shouldn't make a decision on that node at this stage, and to give some time. So I think that's our approach currently, and I think with the aggressive surgical resection that his N1 would propose, we've elected to go this route for the 6 months. So any comments are very welcome. Dr. Lala, maybe something from the endoscopic side, and whether you would venture into something like a full thickness resection in this case.
Thanks, Wayne and Jack and Edward. I think that was quite thorough and quite comprehensive. Yeah, it's tricky. I mean, I think Jack showed the data there for endoscopic resection. The worst thing to do is use a cold snare. I mean, that's goes without saying. You're not getting deep enough to the submucosa, and your chance of getting an R0 resection is going to be the poorest. I think the key to drive with endoscopy is to recognize it, because often you see this small little yellow bump in the rectum, and then you take a biopsy of it, and it comes back as a neuroendocrine tumor. Then it becomes a bit of a challenge to find your area again and to either re-resect it or to go back in and try and then get a margin. An R0 resection is a challenge. So the first major thing is to try and actually recognize it. Yeah, then you need to, I mean, you need to get deeper and get a nice R0 resection, and you're never going to get that with the colds. No, not never, but your rate is going to be very low because you're hardly getting into the submucosa with the cold snare. So you're going to struggle getting R0 resection. A normal EMR is okay, but again, a bit poorer in getting an R0 resection. So if you have the capacity to do a hybrid type procedure, where basically you just make like a circumferential incision around it and then set your snare into that circumferential incision, then you increasing your risks of R0 resections. Going back now, even after it's scarred, you can do an ESD. You can do a intermuscular dissection. For your case, you could potentially do a full thickness resection. One of the problems is you're also going to scar the mesorectal plane, and if you need to go back for surgery, one things we always worry about when we're doing endoscopic therapy is to not make things worse or to not take out other options like surgery. So if you do an ESD or an endoscopic intermuscular dissection, you don't scar the mesorectal plane and you can go back and you can still do surgery. But if you're going full thickness and you scar the plane, that might hamper further or make it more difficult, if not fully hamper further surgical attempts. So that's the problem with doing a full thickness resection. You can use the FDRD device for like your case. Problem with your one is it's going into the mesorectal plane already, and now the chances of getting a full R0 resection, even with an FDRD device or a freehand full thickness resection, is going to be lower. Plus, you're going to scar the plane. So I think in your patient,
surgery.
Yeah, and your patient endoscopic resection is probably not the best move there. If it was an 80-year-old with comorbidities, then yeah, sure, go for it and you've got nothing to lose. But you got a young, fit, healthy, and anxious patient.
Yeah, mind you, he's anxious about having the surgery, but I think the 6 months we'll use, or well, it's now 3 months left
Yeah.
to just convince him that this is the way to go, especially if. So just my last question for you is that would you, I'm not going to biopsy this lesion again, the one in the rectum. I don't think it's going to help us in any case. It's just a matter of imaging,
Yeah.
MRI, and if it's progressing, I think the indication for surgery is clear.
Yeah, I mean, in your case, there's probably no harm in biopsying it because you're not going for an endoscopic attempt anyways. So you're not going to scar it deeply in the mesorectal where you're going to hamper surgery. So it's probably not going to help you, but in this case, it's probably no harm to biopsy it. If an endoscopic attempt was on the cards, then yeah, you're just going to induce fibrosis and make an endoscopic resection a little bit more difficult. But for this case, probably doesn't matter.
Wonderful, wonderful. Thanks for the insights. Any other questions? I see there's a chat. Just a thank you. Thank you, Dr. Veliot. I don't see any other questions. This was a great discussion. Thanks to everyone. If I can then conclude, in the absence of further questions or hands, I'd like to just say thank you to all the speakers. Thanks again to Dr. Edward Miles, who's obliged from AMPAT to give us this detailed discussion on this topic. Thank you to our GI fellow, Dr. Jack. It was great to have you present here and to give such a clear picture of what we were looking for. Thanks to ECHO University of the New Mexico and the ECHO India team. For everyone to remember that these recordings are available on the Gastro Foundation website. Thanks to the Gastro Foundation. Thanks again to the presenters. And to note, next week, Wednesday, will be IBD. Have a good week further, and we'll hope to see you all at the presentation next week. Thank you, and have a good evening.